Hello, everyone, and welcome to the Tertiary Referral Service for Psychosis Webinar Series. My name's Julia Lappin. I'm a consultant psychiatrist and I'm the clinical director for the Tertiary Referral Service for Psychosis, or TRSP. I'm a clinician and researcher working as an associate professor at the UNSW discipline of psychiatry and mental health. And I've got over 20 years experience working clinically and in research aimed at improving outcomes for people living with psychosis. So welcome to the Mindgardens Tertiary Referral Service for Psychosis Seminar Series. The TRSP is a New South Wales Health funded statewide service hosted by South East Sydney Local Health District, and we're grateful to South East Sydney Local Health District, New South Wales Health, and to the Mindgardens Neuroscience Network for their ongoing support of TRSP. I'll begin with an acknowledgement of country and lived experience. So I acknowledge the strength and resilience of Aboriginal and Torres Strait Islander people who are the traditional custodians of the diverse countries from which we're joining this meeting. I'm privileged to be calling from the land of the Gadigal people of the Eora Nation, and I pay my respects to the elders past, present and emerging, and extend that respect to all Aboriginal and Torres Strait Islander people present today. I also acknowledge people with lived experience of mental ill health and recovery, and the experience of people who have been carers, families or supporters. I'll just spend a minute or two explaining for those who don't know what the TRSP is. So we're a service which aims to improve the lives of people living with complex psychosis, and we do so through the delivery of our clinical service, which welcomes referrals from across the state of anyone living with psychosis and cared for in New South Wales public mental health adult services. We also run education and training programs aimed at developing a community of practice for capacity building in complex psychosis care. And this webinar series is an example of that capacity building. The webinar series is supported by Mindgardens Neuroscience Network, of which our speaker today, Jackie Curtis, is the director, and she'll talk a little bit more about Mindgardens today. Mindgardens brings together clinicians, researchers, and people with lived experience to design research and quality improvement projects that match consumers' priorities and make a real difference in people's lives. Our Mindgardens TRSP webinar series will run throughout 2023 monthly. We have one more webinar this year, which we'll provide details of at the end of Jackie's talk. Please also look out for emails from TRSP events, which will detail the future webinars, all tailored for clinicians. Before we start, just a little bit of housekeeping. You can write your questions in Q&A, and there will be a simple anonymous poll towards the end of the webinar. Please complete it, as it helps us understand how worthwhile and informative the webinar is for our audience. We also appreciate your feedback by email, including topics that you would welcome at future webinars, which we're beginning to start programming for 2024. This event is recorded, and we will distribute a link to the event video within 2 weeks to those who have provided us with an email address. You can opt out of our communications at any time with a return email with unsubscribe in the subject line. So it's my great pleasure now to welcome my colleague and fellow psychiatrist, Jackie Curtis, who's an associate professor at the UNSW School of Psychiatry. Jackie's also the executive director for the Mindgardens Neuroscience Network. Jackie has led pioneering work into the development of routine screening and intervention for people living with psychosis to tend to their physical health needs. And it's about that body of work that Jackie will talk to us today. So Jackie, I'll hand over to you. Thanks very much.
Great. Thanks so much, Julia, for the introduction and also for the opportunity to be able to speak to this group around one of my favourite topics, and a topic that I've been focusing on in my clinical and research work for the last 20 years. It's a great privilege to be here today and to be able to share through the Mindgardens TRSP Webinar Series some of that capacity building that Julia just referred to across the state. So I'm very pleased to be here, and thank you for those who have joined. Julia did do an acknowledgement to country, and I'm just going to add my own, given the time of the week and the month that we do. I do want to just acknowledge that there is a really significant referendum this week, and I think we should all, as health professionals, vote yes and acknowledge the important role that the voice could have on the health and well-being and the mental health and well-being of Indigenous people. So I just wanted to add that. So with that, I'd like to just start by going through a whole range of components to this talk, but ending up with hopefully some practical tools for clinicians in order to protect the physical health of people living with psychosis across the domains that you're working in. Okay, so I'm going to cover a few different areas, and the final bit will be some practical resources that you can use and share, and they're new. So even if some of you have heard some of this material before, there's some new information in here that's just been launched a short while ago. So starting with the background of the why this is important, I'm going to actually share a 2-minute video that was developed by Lived Experience Australia, who are an NGO peak body who represent the consumer voice of lived experience. And this was developed and launched last year in conjunction with the Equally Well organisation. It just sets the scene better than I can do it. Okay, so hopefully you've seen that video. I don't know whether the sound came through, but in any case, it really is an advocacy. It's a call to arms for advocacy as much as it is for us to ensure that we ask, advise, act, assess all consumers with experiencing mental health issues. But it's the advocacy part that I think is important as well. And I think we can all have a role in doing something significant there. We started this work a very long time ago, literally 20 years ago, but the growth of the landscape of this topic of physical health and mental illness is really just enormous over this time, including the clinical services and the evidence gleaned from that, the literature evidence, as well as the guidelines and protocols. I'll share some of these, but really it's been hard to keep up with the literature, whereas in the past there was very little there. So I want to share some of that journey with you so you can understand the why this is important, and then the how to do something about it as well, and using a practical example of this. So in terms of what we've been able to do, this is our Keeping the Body in Mind program, which actually was named only in 2013, so 10 years ago, but the body of work linked to that started much earlier. And then it has grown till we now have the Mindgardens Neuroscience Network, adding extra layers of research, translational research, and capacity building to clinicians and researchers with lived experience at the centre to enhance the evidence base to make a difference. So we're trying to, I guess I'm trying to set the scene saying to you that what I'm sharing today is part of this body of work over a long period of time, and it started absolutely from a clinical realm. So you saw from that video that there's this life expectancy gap. And I think, question to ask yourself is, are you aware that the actual life expectancy gap in people living with serious mental illness is greater than the life expectancy gap of Indigenous Australians compared to the average Australian in the general population? Like, we all know that there's a Closing the Gap initiative in the Indigenous population, but what are we doing about this inequality that's greater in our population of people with mental illness? So it's important to know that, again, from the point of view of advocacy and acting on it in a clinical way, in any way that you can, from wherever you are and whatever your role is. In terms of the why, I mean, you saw some of that again in the summarised video, but really the risk factors that are there for the general population that lead to premature death, from the most common causes of death in Australia as cardiovascular disease, but all the risk factors for that are just much higher and occur earlier in people living with mental illness, in particular severe mental illness. But it's not only that, it's also the health inequality that links to that. So despite the higher rates of all of these risk factors, there's actually lower rates of risk factor monitoring that goes on. And an undertreatment, even if someone's detected as having a significant risk factor, it's much less common for somebody with a mental illness to be treated actively for that risk factor, say hypertension or hyperlipidemia, than it is for the general population. And that's despite the fact that people with mental illness actually do turn up to the GPs, often at higher rates, depending on the setting and so on, than the general population. I'm also just mentioning here vaccinations. I'll come back to that, but this is another area of health inequality. And just noting the photograph there, it's just a reminder that I'm speaking here about all the health inequalities, the sort of the medical nursing sorts of factors that we think about. But the other thing that people experience who live with mental illness and then have this comorbidity of physical health complications, they also often put on significant amounts of weight, 10, 20, 30 kilograms. And what is that like for the person? That's a double whammy. You've just been diagnosed with psychosis, but you've also then put on weight. You can't recognize yourself. There's a whole lot of stigma associated with obesity, independent of that of mental health issues. And this is really critical as well to remember. So I'm not only talking about physical health comorbidities and the impact on that on the health system and on the individual, but also on the person having to adapt to something that is is really not something that everybody has to adapt to, and whilst they're also trying to deal with their mental illness. So all things to consider. Looking at the trajectory of these risk factor accumulation, if you look at young people who come into our services before they start on antipsychotic medication, the prevalence of metabolic syndrome, which is listed there as the key features, actually is the same as the general population. So around 6% of people have who are medication naive have metabolic syndrome. But by the time you come into our services, so first episode psychosis services, that 13% is our own data from the Keeping the Body in Mind program at the Bondi Centre. It already's doubled within the first 9 months of coming to us. So those risk factors accumulate early. And by the time you get into our more established mental illness services like rehab units or clozapine clinics and in our community mental health services, again, our own data shows that somewhere between 54 and 62% of that population will have metabolic syndrome, placing them at 2 to 3 times higher risk of dying prematurely. So this is what goes on. Where should we intervene? It's clear. It should be right at the beginning where possible. Now, that's not always possible. You be all looking after consumers in different settings and different trajectory timelines of their illnesses. Something can be done at every stage, but I'm just pointing out here that the earlier, the better. And we'll show you some data that we've been able to do around preventing this trajectory from occurring. Tobacco is mentioned here, and I'll come back to that later, but that's also a huge driver of premature mortality and something that's elevated. The risk of tobacco use is significantly elevated in our populations compared to the general Australian population. This is a paper that really piqued my curiosity. There's lots of papers, there's tens of thousands of papers now compared to when we started this work. But this was a paper that came out last year by that was put into the journal of the College of Cardiology in the US. Now, the cardiologists haven't come along this journey with us as quickly as some other areas, but this was a significant review looking at cardiovascular risk factors in severe mental illness compared to the general population. And so we've known this in other areas, but because this came from the cardiologists who have now turned their attention to this, they've realised this is a significant population to deal with. But have a look at this across, whether it be schizophrenia, bipolar disorder, depression, or compared to the purple, the general population, there are elevated risks of just about all the risk factors that I've just mentioned, including obstructive sleep apnea, which is an important risk factor for metabolic syndrome and so on. There are elevated risks, especially for people with schizophrenia and bipolar disorder, but that's not the only case. So we really need to be thinking of this as a risk factor, mental illness as a risk factor for cardiovascular disease, independently of medications that they're taking, but that's relevant too. So I think this is just a summary of how stark the difference is between, say, the diabetes rate in general population versus schizophrenia, 2.5 times, etc., and even further with dyslipidemia and so on. In the same journal, and I'm really touching on this just to highlight that there are lots of opportunities for intervention. So it might be that there are lots of risk factors for why someone ends up with these enhanced cardiovascular risk factors and behaviours, or in fact cardiovascular disease, but there is a disparity in access to care and the quality of care at each step of the way, and there's opportunities for intervention at each step of the way. And I think we need to remember that too. Even if someone's already developed risk factors and they've got hypertension and diabetes, we need to advocate for those people within our services and our care to get the appropriate level of care for those conditions. So it's never too late to try and do something. However, of course, early intervention is even better. This is, again, another slide from the same paper looking at the different ways, the different barriers and challenges to this and where they lie. I'm not going to go into the detail of this, but there are patient factors, but there's also our health professional factors in terms of our own health literacy, and actually the stigmatisation of consumers, not necessarily hopefully by our mental health workforce, but sometimes by our other health colleagues in ED or cardiologists, endocrinologists, who at times say they don't really want to work with or deal with somebody who's so complex and difficult. Hopefully that's changed, but certainly I've had experience clinically of our consumers not being welcomed into diabetes clinics and so on, despite having diabetes, because they may be disruptive to the services. So we need to actually be thinking about the advocacy piece there as well as the clear health system issues that have come up in terms of even just recording these problems and so on. So there's lots of ways we can intervene. And just to note, I think a very significant paper by one of our esteemed colleagues, Professor Matthew Large, and his then medical student, Sasha Swaraj, last year in Lancet Psychiatry, actually commented, looking at the difference. We focus so much on suicide prevention, and we know that that's really important, and we all have to do our checks and our reviews and reporting of suicide risk and so on. But in fact, by the time you have, this is a paper looking at inpatient mortality. So and we know that we're very risky once you come out of hospital of having elevated rates of suicide. But by the time you get to the 2-year mark of someone having left hospital, the risk of dying of vascular reasons rather than suicide is the primary cause of death. So it's actually, let's rethink how much time we spend on each. It's not to say we shouldn't, that we should ignore suicide prevention, but actually we know that there's a much better evidence base around vascular prevention and intervention than there is suicide prevention. And so let's think about that and think how we could change what you're doing. But is it your destiny? Do you have to end up with all of these problems, physical health-wise? And I'm going to argue that that's not the case, and hopefully we can do something better. What we now know is there's lots of evidence around what can be done to increase the physical health and interventions and prevention activities. But it's not a knowledge gap anymore, but that was the case when we started this work. There wasn't evidence around what you could do about this problem, but now it's an implementation gap. And we know that good evidence doesn't always get implemented. And that's what we're really here about now, and how to intervene appropriately. And finally, on this section, if there is one thing I would recommend that you read if you're very interested in this and want to know more detail. This is the Lancet Commission, which was done a couple of years ago now, but it's the summary. It's one sort of journal of all the information and evidence and what we can do in the different systems too. So for those of you who want more detail, this is the thing to do. And I'm just highlighting a couple of things that we can be looking at, including looking at medication monitoring and, for cardioprotective medications being added in, but also should we be careful about what medications we're actually prescribing. So with that background of the why we are doing this, I want to share with you I'm calling it a real-world example. It's derived from the Keeping the Body and Mind program originally at the Bondi Centre. So to share with you what we've been able to do over time, because each of the steps along the way started from really just an idea and passionate people who wanted to make a difference rather than starting with a lot of funding. We've now evolved it to do a whole lot of more things, but I just want to share briefly the journeys as to, again, why we feel that this is an important topic, but also how to do something about this, basically this lethal discrimination that goes on in our patients. Okay, so that was the picture of the Bondi Centre. Looking inside the Bondi Centre, we transformed a group clinic room where consumers were coming for group interventions. This is the early intervention service there. And we transformed it in 2010 into a gym. It was not purpose-built. We put bits and pieces together by little bits of funding, or from the from the club's funding, from tiny grants here and there, or donations of equipment, and we really formed it into a gym, which is now a real mainstay of that service. But that was a novel thing at that time. It's now staffed by exercise physiology students, and clinical nurse consultant and peer worker, and a dietitian student, dietitian as well. And this is somewhere where there's access to physical health interventions of this kind 5 days a week. But before then, we actually had to think about, well, we see there's a problem. We see at that stage the young consumers putting on weight in front of our eyes, but how do we actually go about measuring or monitoring and doing something about it. And this is where we came up with the initially, long time ago, the metabolic monitoring chart, and then it developed into a district-wide form and then a statewide paper form, and now it's hopefully electronic medical record. Well, we have it. I'm assuming that most LHDs now have the access to this, but think about your service and your setting. Do you have a routine, structured way to monitor physical health? And if you don't, that's the first step. How would you know if a consumer is putting on weight or has got high lipids or hypertension? So you need some mechanism. So that's the first step. Subsequent to that, we developed a tool and which I'll go, the updated version is what I'll share with you today, but this was back in 2010 when we developed this. Was really a tool of how to address all of the things that we were finding on that metabolic chart, which was problems with all of the different factors that are shown there, with the consumer at the centre all the time. And there's Kathy Samaras and Hannah Newell who designed this with me back in 2010. What we then did was we tested whether we could use a lifestyle intervention to improve the trajectory that you saw earlier in the slides. And we were able to our surprise at the time, demonstrate that a 12-week lifestyle intervention for young people within the first 4 weeks of their first episode of psychosis, so that's the first time they were put on antipsychotics. In that first 4 weeks, they got given, they started off with a 12-week intervention, diet and exercise focused, and clinical nurse consultant, as well as a peer worker. And we were able to prevent antipsychotic-induced weight gain, so that in the comparative group, 75% of the young people put on clinically significant weight. That's more than 7%, whereas the Bondi group put on, 13% put on clinically significant weight. Now that's striking. We were surprised about that. We were hopeful, but we were surprised. That led to the Keeping the Body in Mind program being developed, and then the rollout of this program. The first step in the rollout of this program was really looking at, well, would this work outside the Bondi Centre? So we were funded to roll this out across another 3 sites at that stage, and then later a 4th site was put on. And we were able to demonstrate that in that same age population, not in a trial situation, so we weren't comparing it to another service, but we were really able to maintain waist and weight neutrality with just a lifestyle intervention. We're not talking about medication intervention. Lifestyle intervention, very heartening, and this one's going to be published shortly. This led on to a whole body of work. So we employed, and the service had real great vision to actually enable us to have what is now recurrent funded 4 Keeping the Body in Mind teams, each of which have got the nurse component, dietitian, exercise physiology, and peer worker. And they are engaged now in not only the young people, but that was rolled out to adult consumers as well. A whole range of other projects happened as well. This is just sharing the timeline, because it looks like we've got this wonderful program that's just suddenly appeared, but it's actually been a gradation of sort of gradually implemented projects and programs. One of the most important programs we did at the beginning of this was our Keeping Our Staff in Mind project. I'm only touching on this because there's not enough time to go into detail, but we felt that maybe it was a staff culture and attitudes piece that we needed to do first, because we weren't sure if it was going to work outside the Bondi Centre, and we wanted to give the staff an idea of what it is an exercise physiologist or a dietitian actually does and what it would be like for themselves to receive it. So we did an intervention of 212 of the staff across Southeastern Sydney Local Health District, and what we found was that there was a shift in confidence and ability to think about physical health for themselves, and therefore we were hoping that that was going to transfer onto consumer care as well. But we also found physical health benefits for the staff, which we did not expect in a 4-week intervention. It was a mini KBIM intervention. So that was exciting, and if you want to run one of those COSIM trials anywhere else in New South Wales, talk to us. We'd be happy to support that. We then went on to the adult service and looked at how it was applicable in the adult consumers. So this was the first survey. This was led by Julia and the rest of the Keeping the Body in Mind team. We looked at 451 people receiving clozapine across our LHD, and again found these very high rates of overweight, metabolic syndrome, and elevated risk factors. However, the majority of those risk factors were untreated or undertreated. in our own backyard. That's another suggestion I have for those of you in other settings. If you look at what's in your own backyard, it can influence the service managers and the funding bodies to actually do something in your local setting that's different. So that's another major piece of work that was done, and again, as building blocks. And then we finally also did that across those consumers in the community service across the LHD who were receiving long-acting injectables. And as a result of that, we developed an adult keeping the body and mind program, which was a little bit different from the youth one, but had the same principles. Then we moved on to smoking, and again thought, well, let's just adopt a smoking cessation program that's already in existence. It turns out in young people with psychotic illnesses that there was no evidence at that time to guide smoking cessation efforts in people with serious mental illness. And so we got some funding, we developed the Why Quit program, was Y for the youth, and we developed an intervention, a toolkit, and an evaluation. I'm skipping through this fast to just again show you the building blocks of trying to do something in each service in a clinical setting, but then how the resources have been developed as a result of these gaps in the evidence and in the guidelines. So we developed the Why Quit project. We employed and we still have, fortunately, our tobacco treatment specialist in our local health district, but we did interventions across all young people. We offered it to all young people across the LHD who were tobacco users, who had psychosis or who were at risk of psychosis. And we were able to demonstrate a decrease in the number of cigarettes and some other measures of tobacco use. And we've subsequently continued to employ a tobacco treatment specialist, seeing that adds to the way that it's possible to intervene here with tobacco, but something else that often we don't do very well in services. Okay, over to Mindgardens and how this has then continued on to expand the work, and also then led to the development of the new resources, which I'll share. So as Julia mentioned, we bring together groups of our key founding members, the strengths of these 4 major organisations listed here, in order to leverage their strengths to develop and create an expert mental health, drug and alcohol and neurological health hub. So there's multiple components to this. Psychosis flagship is one of our main areas of work, and the TRSP is one of the focal points of that. So, and it's been a great example of what bringing together clinical and research has the capacity to do, make a difference to consumers on the ground, whilst also doing this capacity building of in the education and training space, like this webinar is doing, but also the new research findings that might influence changes of practice and so on. So there's a real value in bringing together, from someone who's come from a clinical background, bringing research into clinical services and marrying those groups together is actually something that we've found to be effective. Mindgardens also has, as part of the psychosis flagship, the Keeping the Body and Mind program. And in that sense, what we've done now is the Keeping the Body and Mind Gardens have just grown the work to other domains. I won't share all the details of that, but for example, KBIM Refugees is a program run out at Addie Road in Marrickville here in Sydney, and it's really adapting some of the work to the refugee and asylum seeker populations. We've got KBIM Primary, which is actually offering the service to people who aren't in the LHD, engaged in the LHD, but actually have a GP who wants to refer them into that. So the University of New South Wales Lifestyle Clinic is responsible for managing that, and Mindgardens is funding and evaluating that as well. So there's just all these different components, and one of them that I will mention briefly is the vaccination project within that. So part of the Keeping the Body and Mind Gardens initiatives, but this was an equally well collaboration, which was a global call to action, acknowledging, and this of course arose during the COVID, peak of the COVID era, where we found that people living with mental illness had actually, almost 5 times the rate of being hospitalised from vaccine preventable conditions, and they were dying prematurely from vaccine preventable conditions, not just COVID. The review was about all the other sorts of things that people in the general population get vaccinated for. So we really want to draw all your attention to this. This is another area of health inequity, but also something we can do about it. And to that effect, Patrick Gould, who's been leading this project and is now working in the Ministry of Health, actually started, though, here in the Southeastern Sydney Local Health District, actually developing up a co-designed vaccine program to see if we can vaccinate more people. People aren't reluctant. People with mental illness are not reluctant to have vaccinations, it turns out. They're reluctant in the same percentage as the general population. So there are reluctant people, but not across the board as people might have thought. So this is actually offering the opportunity and, again, reducing that inequality and access to vaccinations. And we've published a paper linked to that, just showing that COVID's one thing, but there's a whole range of other conditions that people are not getting vaccinated for that we should think about. So watch the space. That's an evolving project. Very briefly on prescribing, for those of you who have a role in prescribing, there's only a couple of simple messages I want to raise here. And this is a fabulous paper that's looking at, from the UK, looking at how the different antipsychotic medications relate to metabolic function in patients with schizophrenia. This busy slide just is a colour map. It's a heat map, so the red means these medications have a really negative impact on the features on the top, whether that be glucose or cholesterol or triglyceride, etc. So we all know that clozapine and olanzapine are the worst offenders, but they're not the only ones who cause havoc with either obesity or other factors. But you can see that there's some orange, so that's the next worst. There's some medications that actually do impact cholesterol, whereas they don't impact weight so much. So for me, this slide says, don't be fooled in thinking just because you're prescribing a lower weight gaining medication that there may be no side effects in terms of other risk factors. So you might not have a weight effect with a medication, but you may have escalating cholesterol levels, so you need to measure, or glucose levels. So this is just saying you've got to screen everybody. And moving along briefly, have to say this, any of you prescribing in first episode psychosis situations, whether that's in ED or anywhere else, olanzapine is a second-line treatment. It's not a first-line treatment. The guidelines all say this, the college guidelines, the Origin guidelines, international guidelines. Major message. The other major message is lifestyle intervention at the time of antipsychotic initiation is now recommended. That wasn't the case when we started this work, but we happily have been able to influence practice in that way. Also, another paper, this has been written around first episode psychosis, key pharmacotherapy principles, but it's really, many of you will see people who are being prescribed for the first time. There's some really good tips in this. This was a recent publication around how to prescribe, but also metabolic monitoring at baseline and regular intervals. I think that's changed practice as well for some time. Okay, the final section is around really what our advocacy piece is and the resources and the policy guides that guide this. So some years ago, we've developed a range of resources that were for young people with first episode psychosis. All of that's available on our iphYs website. But this was how you can advocate and empower consumers by giving them brochures or information on how they can look after their health, but how can they take this information to their GPs? And that includes oral health as well as the general physical health. So I'm really sharing quickly tools you could use in your clinics and practice, depending on the relevant situation. Now, you might say, well, you've got the luxury of exercise physiologists and dietitians, and we don't have that in our service. This was a piece that is for psychiatrists and trainees and actually other mental health professionals about, if you don't have that, what do you need to know and say and do in order to talk about physical activity and how you prescribe physical activity. So this was led by Simon Rosenbaum and Grace McKeon, who are both exercise physiologists, but really a guide of how to do that. Also, if you do have exercise physiologists and they've never worked in mental health, our team have developed a consensus statement on how those clinicians can work within mental health services. So there's lots out there now that wasn't there a while ago. Also for the WHO guidelines, that came late into the piece, but also here's what we need to do. I'm only sharing this in the sense that if you need to argue to anyone, service managers or funding bodies or grants, these are the tools you can use to say, hey, this is what the WHO say, or this is what New South Wales health guidelines recommend. Here they are. These are fairly new, fairly recent, during the last couple of years that this was released. Excellent guidelines. There's fantastic resources through this web link for all of you, of all sorts of resources. So the guidelines there, and it gives you those 4 areas that they want us to all focus on. But there's also tools to help you do that. And that's what's really very valuable about this updated New South Wales health guidelines. So again, if you don't know where to start, here's one place to start. Also, the yes surveys, you may have been aware, but if not, I'm drawing your attention to the fact that in every yes survey in New South Wales, there are factors around the physical health questions, and you can look and rate whether your service is performing on these areas, and you can compare that to other services across New South Wales. Another really good way to see whether consumers are being asked about these factors. And then the Equally Well consensus, which is a national consensus statement, again, guiding principles, helping us all to argue and to mandate for the sake of consumers that we will do better in this physical health front. I don't expect you to see this in detail. This is just a reminder to say that the Equally Well group developed a roadmap about how we can then implement this. And on their first area of intervention for doing, or implementation, I should say, was to develop a clinical guideline, a national guideline that could be rolled out across the colleges, GPs and psychiatrists in particular, but across the workforce. And it says there in small print that Mindgardens will develop this package. So here is the package, and this is the final bit of the presentation. We have developed and recently launched in July the co-designed, digitalized and updated Keeping the Body and Mind resources. And I'll go through those. You can access it through the QR code or through the Mindgardens website, which you'll see multiple times on on this presentation, but also sent out afterwards. The development was, it's taken us a year to do that, perhaps a little more. Steering committees, experts, looking at frameworks and evidence guides across the country and internationally, working out what's the best way to frame this, these new versions, and it's digitalized as well to help you, the clinicians, know what to do. All of it's available on our Mindgardens website. It's going to be updated, the ministry website that I just referred to as well. They're just updating because they're the new, our old ones are there, but the new ones are coming. There are 3 resources. There's adult and then adolescent cardiometabolic health resource, and a brand new tobacco treatment framework. The motto, as previously, is don't just screen, intervene. These were the original algorithms we developed, but now this is the fully updated version. And here's how it looks. It looks similar, except better design than before, looking at all the risk factors in blue that we need to consider. Right up the top is that we should, before we even do anything, actually provide lifestyle advice, diet, physical activity, smoking prevention or cessation to each consumer, and the co-management of physical health with a general practitioner is recommended where possible. Anyone who tips into the red zone, you need to do something about. The red zone's really clear. What numbers do we need to be concerned about, above which? And those have changed. Some of them we've added HbA1c to this compared to previously. We've added a sleep column acknowledging obstructive sleep apnea. All the orange bits are what you can do about it, pharmacological and non-pharmacological interventions, and then what the target aim is in the green. So it's really practical and simple, and it's double-sided. This is the reverse side. It tells you how frequently to monitor, also evidence-based guidelines, why you're doing that, what else you need to look at. So it's not just cardiometabolic health risk, but it recommends the other sorts of things that we need to do. And then if you are going to prescribe metformin, for example, how you do that. Here's the dosing. Or if you do lipid lowering, how do you do that with who does what, the GP versus us, and then antihypertensive treatment, vitamin D, etc. So all the details are there. The digitalized version is going to be uploaded soon as well, but it'll enable you to put in the calculations for your consumer, and it'll come up with all these evidence-based recommendations, and you'll be able to put it into EMR as well. But that bit's not in the update yet, but that second bit's coming. This is the adolescent version, acknowledging there are different numbers for adolescents. again with the frequency of measuring or the metformin dosing, again, a slightly different. And then brand newly developed is this tobacco treatment framework. Just in the interest of time, I'm not going to go into all the details. This looks very complicated. It really isn't. It's just the colour scheme helps us look at which are the pharmacological interventions. So we're putting here varenicline as well as NRT treatment and the evidence for that. And all the blue is you can hyperlink it straight to the more detailed evidence if you want that, but it's not necessary. Then there's behavioural support, and then when you do assessments and how you engage with the consumer to make this all possible. Also how you test for someone being addicted to tobacco or not, and so on. And the reverse of that also gives you the ABCs of how to do this. It's more complex because the NRT and the varenicline piece are, it's not as straightforward as the other algorithm. But hopefully with withdrawal symptoms noted and how you get NRT and which MBS items they relate to, hopefully this will be another useful clinical tool alongside of video training resources for clinicians on those three topics: nutrition, physical activity, and tobacco. And we've revised the paper modules that we've developed years ago to the digitalized version online. So this is if you don't have any clinicians, exercise physiologists, etc., who can specialize the interventions, you can use these yourselves, whatever clinician type you are, or it can be support workers, it could even be family or carer. And here are the headings. These are all the sorts of things you can intervene with, but real practical working workbooks that you can go through, all available digitally. And finally, the oral health resources as well, which were co-designed, and acknowledging that this oral health is really important as well. That's the final same code, but you'll get the copies of that, and we send that round with the feedback. It's a thank you to a lot of people who this work has been involved with. This has been a big body of work over a long period of time, and we're really wanting to empower you as a community across New South Wales in all settings to make a difference. It's a work in progress. Please contact us if you have any desire to collaborate or questions. And now I'm wrapping up and saying thank you and handing back over to Julia.
Thanks so much, Jackie, for a wonderful talk, and just a quick whistle-stop tour around all the many steps that you've taken over the past couple of decades in really developing and growing this really important body of work around improving physical health in people with severe mental illness. So thank you so much for that summary. Jackie, we are going to move to the Q&A session, but before we do so, if you wouldn't mind just to click through the next few slides and I'll speak to those, and I'll encourage people while I speak to these to have a think about questions that you have for Jackie, and please add them to the Q&A. While you're doing that, everyone, I just want to introduce the final webinar in our TRSP Webinar Series, which will take place next month on the 8th of November. And I'm going to give that talk. And that's going to be a summary. Really, we've had lots of inquiries about the TRSP. So we thought it would be a good way to end the series this year by my providing a summary of what we do in the clinical service, and also talking through some of the outcomes that we have been able to assess in people who've been looked after by our service, demonstrating that we really can, through holistic collaborative care planning, improve clinical and functional outcomes for people, even those living in quite challenging circumstances. So I hope that you'll join us next month for that final webinar for 2023. And information about that event will, of course, be sent out. And next slide, Jackie, thank you. If you would like to contact us to discuss the webinars or a referral, this is our email address. We'd really be delighted to hear from you. And the final slide is a contact information slide about the Mindgardens Neuroscience Network. And you can see that there are many routes with which to learn more about what Mindgardens is doing. So thanks for that, Jackie. I think we'll stop screen sharing and then we can join the gallery and start addressing some of the questions from your talk. I might just kick us off, Jackie, because I think, you know, it was really wonderful to see in your talk the experience really of you as a clinician, recognizing that there were significant physical health issues which were going unaddressed in your population, and then really just championing that issue and slowly and with patience, building up a team, building up a body of work to validate the work that you were doing. I expect for many clinicians who are watching the webinar, they very much want to assist in enabling the people they care for to have better physical health, but just don't really know where to start. So, I mean, there are now, as you say, lots of resources, and it's wonderful to have the resources that you shared at the end there, which sort of gives people direction into first steps. But if you could encourage people who do feel motivated to try and improve the physical health for people in their care, do you have any sort of first steps that people could make in order to really start to make a difference and improve their own knowledge about what needs to happen next?
Yeah, no, it's a great question, Julia, and you know, you've been part of this journey for a particular part of time too. But it really looks like we've done so much, but it's been so gradual. And you know, I worked entirely as a clinician in the beginning of that, and all really, for me, the way it was possible to move forward at all was to have another buddy or a couple of buddies. So we really just started a small interest group initially, in a way. Well, we've got a metabolic monitoring interest group. What do we do? So we just met with a few of our colleagues, different disciplines, and said, what could we do? So I think that's it. Try not to do it alone, because if you're a lone voice, it's hard. If you've got anyone else interested, I mean, we had fabulous nurses who really drove a lot of this, and then colleagues from the university who knew what they were doing with trying to do something research-wise, which I had no idea about in those days, and pulling that together. And now at that stage, there was no guide at all, but now look together, sit together and think, you know, is there a journal club or something we could do, just a small group of us? Let's look at the guidelines and work out what we could do in our own service. Also now, Mindgardens and KBM Gardens is a resource for you. So reach out to us. If we've been helping other services, we've been doing some work in parts of Western Sydney and Western New South Wales to help other services develop platforms and programs. So we'd be very happy to share. But everything on our website is designed for you at the clinical level to try and build your knowledge. So even those videos, it's 15 minutes each. Just start with something and be encouraged that you can make a difference. You can make a difference.
That's great, Jackie. And I think, you know, I think my experience of a lot of the work that you've done is absolutely working with others, but the power that someone really championing an important issue has can really drive change. It's small steps initially, but then you can, you know, now you've got all this evidence to back up what you're doing that others can draw on to. And it's great to understand that at Mindgardens you're really keen to support clinicians across the state.
No, absolutely. Julia, I can just see someone's commented about the shame that there's no OTs were included in your MDT. I just want to clarify that. That's not the case. What happened was OTs were part of the early psychosis program team already. So they were centrally involved because they were running groups, etc. What we added was the new clinicians that weren't previously funded, were the exercise physiologist, dietitian, and peer worker, and a clinical nurse consultant that was specialized in the physical health. So we added that to the team. The OT was central to the program and getting consumers along to things. So in terms of the new staff, that's what the Keeping the Body in Mind program did. Yeah. Sorry, just
right. Thanks, Jackie. And then perhaps we'll just move through the rest of the questions. So Someone has asked whether it's possible to share the quality prescribing and early psychosis practical guide.
Let's share that through your communication after this. Yes, absolutely. Happy
That's
to share.
right. So in the email that follows this webinar over the next 2 weeks, we can include that resource for everybody who's provided an email address. Then, Jackie, we've got a question from Pete. Could you tell us more about the intervention and outcomes for physical health with the clozapine clinic consumers who had long-standing illness?
So what we did with that was we adapted the program, the 12-week youth program wasn't so neatly sort of feasible or probably acceptable to the adult consumers. So we worked out what else was possible. So it's more of a group program. It was disrupted majorly during COVID, but it was basically people who were on clozapine were invited through the peer worker as well as through the rest of the team to come and join a group program, which was in another setting. We would pick people up. They do cooking sorts of things, exercise types of things. Tobacco cessation was inside there as well. And we've got some outcomes. We haven't published those yet, but what we were able to show, I don't think, was that we were able to prevent further weight gain. So it's not like so much weight loss in that situation, but actually healthy. We were able to get some people to stop smoking and some weight maintenance rather than gain. The other thing is you help people go along to, for example, breast screens or get their vaccinations and other things that are relevant too. So certainly that program is ongoing. Yeah.
Thanks, Jackie. And then there's a question around motivation in consumers. How did you work with the consumers with low motivation around KBIM interventions like gym and diet?
Yeah, no, that's also a really good question. It's not for everyone, the gym and diet program, even for young people who you'd think all of them would want to do this. We certainly utilise the peer worker. So the KBIM peer worker, I was trained in health coaching as well, and actually because it's not just about what would the person like to do. I want to smoke and I don't want to exercise. I won't worry about that. We actually train them in why this would be helpful to come and join very small bits. So it's not about the gym. It might be walking, or it might be, it might not be something we can ever persuade someone to come to, but we still have to address the hypertension or the dyslipidemia and treat that medically. So there's a combinations of things, but we do keep persisting. And the OT was one of the ones who used to ring somebody up all the time to say, come on, come today, and would help engage with the whole team. So the whole team, the clinical team, thinks of KBIM as part of their team, and they all work together trying to say, well, this is core business. Like, you don't say, well, I'm not going to see the family work, or maybe you do, but you're trying to build this across the culture of the whole team to say this is important. It's something we keep working on, and it's not, you'd be surprised how even people with low motivation can actually be encouraged to do small things. Often it's the social piece or eating, cooking together and eating together. That's more important.
Thanks, Jackie. Then we've got a couple of questions relating to inpatient settings. So one asks, have there been any clear guidelines of effective lifestyle interventions implemented within inpatient settings? And secondly, how do you improve compliance within inpatient units who don't yet have electronic records?
Yes. Okay. So the inpatient units really have the same recommendations and as in terms of the New South Wales guidelines as the community ones. It's just actually, it even tells you how often you should be screening and measuring things, and how soon after admission you should make sure there's a physical examination and other tests compared to a community admission. So the guidelines are there. Look at the New South Wales health ones. In terms of the electronic medical records, if they're not available in your LHD, then there's a statewide paper form. So again, we can help to share that, but that's totally reasonable to be using. It was really workshopped at great detail, and the electronic one comes from the paper one, so use the paper one. I think it needs to be a culture, again, of the service doing that and working out how that's done. Our service has employed physical health nurses into the inpatient units so separate to the KBIM team, in order to ensure this bit's being done. Often it needs nursing champions that can help with that. This should be routine business, just like taking someone's pulse and blood pressure is in the wards for other things. setting a system up is really important. Yes, there's been plenty of evidence that people do that. They don't do it well in many places, but this is another project waiting to happen. And we had a lovely presentation last week, Julia, from I think it was Alex from Shell Harbour or Shoalhaven, I'm going to get this wrong, who presented around an inpatient rehab setting and doing some work and championing a quality improvement project in the rehab setting. So I think speaking to others who've done it is worthwhile and relevant.
Right, Jackie. Alex was a dietitian down in Wollongong, and she's really been able to affect improved physical health outcomes in an inpatient setting. So perhaps we could refer you on to information about that work. If you could just provide us after the webinar with your full name. Jackie, we have more questions. I'm afraid we're going to have to call time because we've hit 1 o'clock, and we will forward you, Jackie, the rest of the questions, and it may be that you would be able to answer some of them, and we can include responses to those questions in the information that we send out after the webinar. So in the last couple of moments, I'd just like to thank Jackie very much again for a wonderful talk. And Jackie, thanks for showing us through all your wonderful work on physical health in people with severe mental illness. Thanks, everyone. Goodbye.